All right, so good evening. My name is Tim Gibbs with Delaware Health Force. Glad to have you here on this fourth session of Delaware Mini Medical School that we're proud to present with Bay Health. Yeah, let's get this started. All right, so I mentioned the YouTube streaming. The direct link is in the chat, or you can go to youtube.com/Delamed302 and then click on live. There are the links for Delaware MiniMed in partnership with the Sussex Coalition. Wanted to reinforce again that there is a special program, Pathway to Physician, that's being presented by the Department of Health and Social Services, the Delaware Institution for Medical Education and Research, and the Delaware Health Sciences Alliance. There is the, whoops, I didn't intend to click. There's the URL for that. And again, we will put that in the chat here in a bit. Housekeeping tips, just to remind, this is a webinar, not a meeting. You don't see each other. We don't see you except for when you enter a question in Q&A. Please do use the Q&A to ask your questions. We'll take care of housekeeping things as the presentation goes along. We'll handle or hold most of the clinical questions to the end for the presenters to address. And please make sure that any clinical questions are not of a personal or family nature. And also, we do need to stay on topic relative to what the presenters are talking about, which this evening is pharmacy. You need to stay through the entire presentation, but once the presentation is over, and we've started into the Q&A. At that point, you can leave. You'll still be counted as being present. And at this point, I would like to turn it over to my friend and colleague, Christy Hanley, with the Sussex County Health Coalition. Christy.
Great. Thank you, Tim, and welcome everyone. I will be putting some information in the chat about Sussex County Health Coalition. Please feel free to go into the link, check us out, and see what we are doing for Go Purple for the month of October and November. So it is my pleasure to introduce our guest this evening from Bay Health. I'm going to let Tim switch the slides for me. So first off, I would like to introduce Candice Watts. She's a certified pharmacy tech and inpatient technician supervisor for the Kent campus. We also have Katherine Jarmon, who is a patient care pharmacist at Bay Health Sussex Medical Center. We have Carl Popelas, who is the clinical manager of the Department of Pharmacy Services. And we have Cheri Briggs, who serves as the Senior Director of Pharmacy for the health system and has experience in a variety of pharmacy practice settings. I'm going to turn it over to our presenters.
All righty. And at this point, Carl, you can go ahead and share screen. And we can see it. Great.
I'll be the first presenter getting started with exploring the world of pharmacy. Again, my name is Candice Watts, and I'm a certified pharmacy technician with Bay Health. I'm the technician supervisor for the Kent campus. Next screen, Carl. All right, so I'll be presenting on what a day in the life looks like as a pharmacy technician. First, just going over Bay Health's core values: compassion, accountability, respect, integrity, and teamwork. Those are all of our core values and something that we embody each day as we do our jobs. All right, as a certified pharmacy technician, for inpatient, we are responsible for distributing pharmaceuticals, performing inventory control, preparations and distributions of intravenous admixtures, maintenance in the clean room, also compliance audits, providing customer service, and maintaining pharmacy records. Just a brief list of things that we do throughout the course of the day. We deliver medications to our automation dispensing cabinets, which are called Pyxis med stations. We prepare medication for delivery up to the nursing units, compounding IVs for the entire hospital, compounding chemotherapy for oncology patients, record keeping, inspections, IV room and IV hood cleaning and maintenance, as well as repackaging of bulk medication so that we can distribute to the patients on the floors. We also triage phone calls as they come into the inpatient pharmacy from nursing for whatever questions or needs that the nurses may have, and to the pharmacy, assisting nurses with Pyxis and medication delivery related issues, whether or not they need to locate a medication or if they need help with any items that they may need assistance with. Technicians are also a key part of helping our pharmacists with their daily tasks as well. And we support the organization by maintaining a high reliability environment by following all of the safety measures to make sure that we're providing the best care for our patients. Next screen, please, Carl. For our outpatient pharmacy, they have a different list of tasks that they perform. They process prescriptions, they bill third-party insurances, they administer immunizations and inventory control, record keeping. They also do inspections in outpatient pharmacy. They triage phone calls. We also have a program called Meds to Beds where we hand deliver medications to the bedside for our patients to make things easier for our patients upon discharge, so they don't have to wait in line or go to the pharmacy to pick up their medications after being discharged from a hospital stay. Pharmacy technicians also help with the medication ordering to make sure that we have all the medications that we need for our patients, assisting pharmacists in their daily tasks as well. And they also support the organization by maintaining a high reliability environment for safety measures for our patients. As a pharmacy technician, you have your typical areas where we are in outpatient or retail settings, also in inpatient settings, but there's actually a long list of opportunities and career options as a pharmacy technician that you are able to do as well. We have an automation technician, we have a pharmacy buyer that is under the inpatient umbrella that is just solely dedicated to purchasing medications and supplies and all the things that we need in our inpatient setting. We have an inventory specialist, med reconciliation, pharmacy technicians, certified pharmacy technicians come at different levels, 1, 2, and 3. We have sterile product lead technicians, 340B specialists, regulatory readiness technicians, operating room inventory technicians, and also you have your outpatient and inpatient technician supervisor like myself. Again, being a pharmacy technician is not just a job, it's a career, and a career that comes with under Bay Health, a pretty amazing list of health and wellness benefits as well, vision, workers' compensation, dental, life insurance. As you can see, there's a long list of benefits that come with being a Bay Health employee and working as a pharmacy technician. We also have the opportunity to have sick time, family medical leave, paid leave for time off and holidays. We also have annual performance reviews that are an incentive for us as well. Service awards, tuition reimbursements. I have a number of technicians that are actively in school while working as pharmacy technicians, and you're able to go to school and be reimbursed for your education as well as a Bay Health employee. Some additional benefits that we have at Bay Health. are also for retirement and employee cafeteria discounts, which is always a plus. And that is my presentation for pharmacy technicians at Bay Health. Thank you.
And then put your mouse back over here.
Hey guys, I am Katherine Jarmon. I graduated Sussex Central High School from Georgetown in 2000, and I graduated with my PharmD from Shenandoah University in Winchester, Virginia in 2007. I worked as a retail pharmacist after graduation until the fall of 22 when I joined the Bay Health team as a patient care pharmacist. My job as a pharmacist here is to verify orders from the doctors, to check IV medications, chemo medications. And then one of the neat things that we also do is we go on rounds up on the floors, and we joined in with multidisciplinary rounds. So that's where the patient's care team comes. We round on each patient, and we do that every morning. It's a lot of fun. So why did I pick this topic? So my title is Xylazine U and why awareness matters. The reason I picked this is because as a patient care pharmacist, we work weird times of the day. So we work evenings, we work overnights, we work during the day. All shifts have to be covered at a 24-hour pharmacy. So to understand how illegal drugs work and regular drugs, you have to know both. So all drugs work in a certain amount of time. So when you take a medication or a substance, there is a period of time at which it comes to its peak concentration, which means it comes to its highest concentration, as you'll see on the table. And then after a period of time, it's going to come out of the bloodstream, or what we call elimination. So as a hospital pharmacist, we need to know what our patients are taking and why they're taking it, and how we can better assist the doctors to assist them with their medication treatment plans. And if we don't know the answer, we need to be able to figure out the resources to help them find the answers that they need to help the patient. So what exactly is xylazine? Xylazine is an FDA-approved medication only for veterinary use. Again, it's only approved for veterinary use. It is approved for procedural sedation. So the examples of that are dog grooming. If a dog or a cat needs its teeth pulled or cleaned, horses, cows, if they need wound cleaning, stitches, biopsies, etc., all kinds of stuff. It is approved for animals big to small, so mice to sheep to elk to horses, cows, you name it. There is a dosing protocol that they can use xylazine for. Note, it is not approved in humans. It slows our heart too much, and it gives us severe side effects. So where did it come from? So in 1962, the Bayer company founded this in Leverkusen, Germany, and they were going to use it to try to help lower blood pressure. The FDA approved it in 1972 for procedural sedation, again, only for veterinary medicine. However, in the early 2000s, we started to see the first emergence of illicit drug use in Puerto Rico and Philadelphia. So how is it supplied? For the veterinarians and medical use, they're going to see names like Xylamed or Rompun. On the street, the drug dealers and the drug users, they might know it more so as Trank or Philly Dope or Zombie Drug. It comes as multiple strengths, again, because you have small animals and large animals. Small animals are not going to need as much as a large animal. So it comes as 20 milligrams per milliliter, 50 milligrams per milliliter, 100 milligrams per milliliter, 200 milligrams per milliliter, and 300 milligrams per milliliter. Again, you need a higher concentration for a bigger animal because they're going to need a larger dose. So with the animals, because this is used for sedation or to help put them to sleep, we're going to see side effects that are going to mimic that. So muscle relaxation, slowed breathing, lower blood pressure. They're going to have disorientation, drowsiness, blurry vision, anything that you would think about that. And that's going to help them to go to sleep. However, with humans and the overdose, we see a completely different picture. The reason we see that different picture is because with the animals, they are getting pure xylazine. However, in humans, we're using it as an adulterant, meaning we're using it as a drug that is mixed with another drug. So then it's going to give us a different picture. So the best way I can kind of explain that is if you have yellow dye and you have blue dye, you end up with green dye. So think of yellow dye as fentanyl, blue dye as xylazine, and then yellow plus blue mixed together is the fentanyl and the xylazine. So with the fentanyl, you see certain side effects. With the xylazine, you see certain side effects. And then when you mix them together, you see different side effects. Now, note, the way that xylazine works is different than the way that an opioid works. So like fentanyl or heroin. However, we will still give people Narcan. It will not reverse the xylazine, but in an overdose situation, the paramedics and EMTs, they're still going to give Narcan because it is still possibly going to save that person's life. Note, there is not an FDA-approved medication or a treatment plan for a patient who is having a xylazine-related drug overdose or withdrawal. We are doing the best that we can to try to draw data from Philadelphia area hospitals and other hospitals that have done research on this, but there is still not an actual FDA-approved list of treatment options or medication. We're just doing the best we can to try to figure things out. In terms of veterinary, though, there is a reversal agent. Yohimbine or tolazine are both used in animals. However, in people, what we have found is that actually puts people into severe withdrawal side effects. So that is not a good option for a person. Now, something that I find really interesting is that one of the big side effects that we are seeing are these xylazine wounds. So the wounds can appear anywhere on the body, regardless of where somebody's injecting. Typically, we'll see them in the arms or in the legs. It does not matter if they are injecting, if they are smoking it, if they're snorting it. Even if they are smoking or snorting, we can still see these wounds. So it is not injection dependent. They can look like a combination of blisters, small scabs, large ulcers, or like dark or black pieces of dead skin tissue. Now, if somebody is having this type of a wound, remember that not every wound is actually infected. So they don't have to take antibiotics if it's not actually infected yet. So they just want to keep their skin moisturized with like an A&D ointment. They want to avoid using any sort of alcohol or hydrogen peroxide on the wound, anything that's going to dry it out more. They want to make sure to keep the wounds covered with a clean bandage and to wear long sleeves, pants, socks, or gloves to help prevent them from scratching their skin. Also, want to make sure that they are not injecting in that wound because injecting into the wound is just going to make it that much worse. So why do I draw a picture to these skin wounds so much is because the wounds can increase the risk of blood infections, can increase the risk of heart infections, limb amputations, and then if it's not treated, it can cause death. So did you know that in 2023, xylazine was actually involved in 38% of all unintentional overdose deaths in Philadelphia? 100% of xylazine deaths are also involved fentanyl and or fentanyl analogs. According to the DEA, xylazine is making the deadliest drug threat our country has ever faced, fentanyl even deadlier. So why is this such a problem? It's inexpensive and it's easy to get. By adding xylazine to the drug supply, it's stretching the dealer's supply and allowing them to get more bundles that they can sell to their customers. So what we think happens right now is that there is a synergistic effect. So it works together with the opioids like fentanyl or the heroin. The high from the fentanyl doesn't last as long as the high from the heroin or other opioids, but the xylazine added to the fentanyl actually mimics that high of the heroin. So then they can stay high longer. So it's a perfect storm because the dealer is getting more money because they're stretching their drug supply. The user thinks they're getting a better high, and then this is just creating an absolute disaster in the hospitals because it's causing a lot of overdose and a lot of deaths that are unnecessary. So what are we doing on a government level to help? So several states have actually enacted legislation to try to make xylazine a controlled substance. So when I say it makes them a controlled substance, what I mean by that is there's 5 different medication control classes. There's Schedule 1, which is high abuse potential, and there's no accepted medical use. Schedule 2 is high abuse potential. However, they do have an accepted medical use. Schedule 3 is an intermediate abuse potential, more so than Schedule 2, but less than Schedule 4. Schedule 4 has a abuse potential less than Schedule 2, but more than Schedule 5. And Schedule 5 is medications with the least potential for abuse among the controlled substances. So May 5th, 2023, Delaware declared xylazine a C3 controlled substance under an emergency regulation. However, federally, it is still not a controlled substance. However, it does require a prescription and is not sold over the counter. February 12th, 2025, the Combating Illicit Xylazine Act was introduced to committee. There are identical bills in both the Senate and the House. However, they are just sitting in committee right this second. They have not passed, they have not become law yet. And what that's going to do is that is an act to try to get xylazine to be a federally designated C3 controlled substance. Also, in July of 2023, the White House released what they called the Fentanyl Adulterated or Associated with Xylazine Response Plan. What that is that is a instructional groundwork for a nationwide response, including Border Patrol, including medical, where we need more studies at, how we're going to try to manipulate things so that it doesn't get in our drug supply. You name it, it's in there. It's a really, really good resource for how the government's actually trying to do it. And it looks like they haven't left a stone unturned. But at the same time, for where we are right now, it's going to take a while to actually get there. Now, as a pharmacist, what this means to me and why does this all matter is because we need to understand who is coming through our emergency departments. We need to know how to recommend those treatment options if we are asked. We need to be able to stay up to date with new diseases, infections, and drugs that are up and coming in every aspect, locally, regionally, nationally, and globally. And we need to be the best resource possible for our patients and for our physicians. All right, I am going to turn it over to Carl now.
Good evening, everybody. My name is Carl Popelas. I am the clinical manager and oncology pharmacist for Bath Medical Center. A little bit about myself is I graduated from the Philadelphia College of Pharmacy back in 2001, and I went straight into retail, which is like your Walgreens and your Rite Aids, and I did a year there and realized I wanted to do a little bit more with my knowledge, so I came to Bay Health, and from there I went into clinical pharmacy. I went into oncology, which is the study of cancer, and also now I'm the clinical manager. So today I'm going to go over a little bit about what a clinical pharmacist is, because I think a lot of people don't realize that clinical pharmacists even exist. So when you think of pharmacy, you think of the person at your retail and your Walgreens, your Walmarts, things like that behind the counter. But people don't realize what's actually done in the hospital and the specialties that can occur. And then after we go over that a little bit, we'll go over some cancer medications and then a patient case. So you can kind of get an idea of what clinical pharmacists really do in the hospital. So by definition, clinical pharmacists are pharmacists that work closely with doctors, nurses, other healthcare professionals, and also patients. And the goal is to really achieve the best possible outcome for the patient. And we do this by improving medication therapy, and that is by dosing medications by blood levels, by organ function, so kidney and liver function, also medication interactions by adjusting medication dosage appropriately, and then also looking at concomitant disease states that patients may have and kind of adjusting medications according to the disease states. So within clinical pharmacy, there's a lot of areas of specialty that you can have. For instance, at Bay Health, we actually have several programs here where we have experts in our field. Experts are pharmacists that are board certified. They do extra training to become certified in their area. So we have one pharmacist that does antimicrobial stewardship, and he really just looks at the appropriate use of antibiotics to make sure that they're being used appropriately and not overprescribed. We have pharmacists that do pain management, and they just look at patients, manage patients all day long to make sure that their pain is controlled. We have pharmacists that work in anticoagulation clinics, and they deal with blood thinners for patients. We also have positions for emergency medicine, where the pharmacist will be in the emergency room seeing patients that are in trauma or need urgent care. We also have critical care patients and oncology. And since oncology is kind of what my passion is and what I like to do the most, I'm going to go over a little bit about cancer medications and what cancer is. So first, before we get into medications, I think, it's important that everybody kind of understand what cancer is. So really what it is by definition is cells that just grow rapidly and uncontrollably. And because of this, they have the ability to take over healthy cells, crowd them out, and then can spread to other parts of the body when conditions are correct. There are several ways to treat cancer. It's not just medications, but you have surgery, radiation, and then different subclasses of medications. And usually there's a combined in some way, whether it's medications with surgery or radiation with medication, or possibly all three. But you would use them all the combination to treat the patients appropriately. And then within the medications, you have different subclasses or broad categories of cancer treatment that we'll go over here in a second. So really first is chemotherapy. So as I said earlier, cancer is cells that grow really rapidly and uncontrollably. So chemotherapy is just medication that's designed to kill any cells that rapidly grow. And that could be targeting the cell cycle, that can be affecting the DNA within the tumor cells, blocking enzymes or proteins that the cancer cells need to survive. With that, unfortunately, healthy cells get damaged also. So typical healthy cells that grow very rapidly are the ones in the stomach and the intestines, the hair follicles, and the bone marrow. So when you think of chemotherapy, you think of your traditional side effects, such as getting sick to your stomach, hair loss, and having trouble fighting infection because the bone marrow is being decreased. A newer category of cancer treatment is immune therapies. So the immune system does a great job of tracking down and killing cells that aren't appropriate or cancer cells, but every once in a while those cells get through, and then they're able to turn that immune system off. So immune therapies are basically just medications that will amp up the immune system, make it work better, and then recognize and kill these bad cells. And with these, they have their own unique side effects, which are really hyperactive immune system and anything that can be inflamed. So any organ system, including the skin, the stomach, the kidneys, anything that can be inflamed and cause issues. And then the last broad category is your targeted therapies. So cells in the body normally have signals that are tell them to stop growing. Tumor cells a lot of times have an on-off switch, and the switch is flipped on, and it just keeps getting a signal to grow. So this targeted therapy goes after specific mutations, and it tells the tumor cell to stop growing. It just flips that signal off. So it'll target specific mutations within the cancer. So to drive home kind of what the pharmacists do, and I just want to give like a fake patient case. So you kind of see what we go through and what our thought process is for dealing with, at least for cancer patients. So this patient case has a patient that's diagnosed with cancer, has a history of heartburn, and the physician decides to treat the patient with two medications. The first is called capecitabine, and that's a tablet that's taken by mouth, and that will target specific enzymes within the tumor. And then there's also oxaliplatin, which is given through the veins, and that will target DNA to help stop those cells from growing. As pharmacists, what we'll look at the height and weight. We'll look at the kidney and liver function to see how patients can respond to medications. And we'll also look at the other disease states they may have and medication interactions. And we'll kind of go through each one of these singly. So the first one is the patient height and weight. So this is important for calculating what's called a body surface area. So the body surface area is really just the area the body encompasses, and this correlates with functions of the body. So chemotherapy is dosed generally by body surface area and sometimes just by plain weight, but majority of them are body surface area. We also evaluate kidney function. So to evaluate kidney function, we use a marker in the blood called creatinine. And what this is really just a protein that's broken down by the muscle. It goes into the bloodstream and removed by the kidneys. So we plug this into a formula and we get what's known as a creatinine clearance. So the higher the creatinine clearance, the better the kidneys are working. The lower it is, the worse the kidneys are working. We would also look at liver function and determine by using the enzyme specific to liver whether or not the liver is functioning correctly or not. So in this particular patient, we're going to say he's 6 feet tall, weighs 170 pounds, and have 77 kilograms in parentheses because in the hospital we use the metric system. So using those two, we plug this into a formula and we get the body surface area, which is 1.97. We also look at his kidney function and we see that serum creatinine is 2.1. Normally it's anywhere between 0.6 and 1.2. So we'll plug this into the formula, and this formula is not really important for this talk, but what it's important to show is that, you know, even as adults in medicine, we still use math, so it's still very important to know math. So 2.1 is a little high, and then, you know, set his calculation at 33 milliliters per minute, which is a little low for kidney function. We'll say that his liver function is normal and his other health issues is his heartburn. So as a pharmacist, we also review his medication list. So we'll say for his heartburn, he's taking pantoprazole once daily, and he also takes a multivitamin to try and stay healthy. Again, these formulas are not important. This is just to show that there is math involved in pharmacy. So looking at his oxaliplatin, you work the math out, and his dose comes to 256 milligrams. He gets that every 21 days, and he'll get 4 doses of that. And then the capecitabine, he'll get 1,970 milligrams twice a day, but he only takes that days 1 through 14. Then he's off a week, and then he starts back on it for 4 cycles. So as a pharmacist, looking at his kidney function, we see that remember that his creatinine clearance was 33. And so as a pharmacist, we know that this requires a dose reduction for his capecitabine. So any creatinine clearance under 50 would require a dose reduction. So instead of being 1,970 milligrams, reduce his dose to 1,500 milligrams twice daily. And that's really to give his body the ability to clear the medicine. Otherwise, it can build up in the system, become toxic. Also, as a pharmacist, we look at his medication list. That's very important. So there is some data showing that these heartburn medications can decrease how well capecitabine works. You know, with there being mixed data, we want to give this patient the best possible outcomes that he can get. So we'll counsel the patient to stop the pantoprazole if he can stop it. And if he's able to, we can use antacids instead. And then, of course, lastly, we'll talk to the medication and talk to the patient and do counseling. We'll talk to him how to handle it. We'll discuss how to store it, how he can properly take it and dispose of it because it is hazardous. And then we always go over the side effects that it can cause, and also prevention and management techniques for the side effects if he does get them. And that was my talk on clinical pharmacy. I thank you, and I will now turn it over to Cheri Briggs, who is the Director of Pharmacy for Bay Health.
Good evening, everyone. So as Carl said, I am Cheri Briggs. I am the Senior Director of Pharmacy at Bay Health. I graduated from the same place that Carl did, which is the Philadelphia College of Pharmacy and Sciences. That also now is known as St. Joseph University, with a bachelor's in pharmacy. Then I have a doctorate in pharmacy from the University of Florida, Master of Business Administration from Rowan University. I'm also certified in Lean Six Sigma and medication therapy management. And I've been at Bay Health for 5 years, where I serve as the Senior Director of Pharmacy, but I have experience working in many other practice settings, such as acute care, home infusion, long-term care, pharmacy, long-term acute care hospital. I'm also a member of the American Society of Health System Pharmacy, where I actually serve as the chair of the Council on Public Policy. I'm a fellow of the American College of Healthcare Executives. I'm a delegate to ASHP representing the state of Delaware. I'm also the vice president of the state of Delaware of the Board of Pharmacy, and I am on the Delaware Controlled Substances Advisory Committee. Next slide, please. So what I wanted to talk about was my career path, but before we go into that, what I wanted to do was to summarize basically what everyone else has said. So Candice started, and she starts as the pharmacy technician in our hospital. And this talk is really only referencing hospital. And so technicians in hospitals serve as the backbone of pharmacy. We couldn't do it without them. I absolutely need and love all the pharmacy technicians that are within the team. Patient care pharmacists such as Katie, they oversee the work of the pharmacy technicians, and they keep the practice and the operations of pharmacy running smoothly. Again, they oversee what they do, and they absolutely are the backbone of what we do as well. Clinical pharmacists is what Carl talked about, and they work hand in hand with the other medical disciplines on the floor. Patient care pharmacists also go on the floor, but they work hand in hand with them on a more concentrated level. Clinical pharmacy specialists, such as Carl and the other ones that he said, actually are board certified. They may or may not complete a residency, but they receive the additional training. And then for me, I wrap my arms around everything within practice of pharmacy, and we provide work on a strategic plan to achieve the organization's objectives. So my overview is of everything at Bay Health, not only just practice of pharmacy, but everything. And as you know, particularly in healthcare, as we discussed, pharmacists in hospital advise physicians and other healthcare practitioners, mid-level practitioners, such as PAs and NPs, on the appropriate use of medication. So anytime in a hospital that you see a medication being prescribed, there's a good pharmacist behind that medication. We're keeping patients safe. We're making sure that everything is done appropriately and accurately. And hospital health system can't make it without pharmacists doing things appropriately. So my career path was actually, I worked in pharmacy that serviced nursing home, as I said before. Then I got promoted. I got promoted to being an IV supervisor because whenever I started out in pharmacy school, I worked both in retail and I also worked in hospital. I moved back to the East Coast. I became a director that way, and where I currently am. And as I said, I'm on all these different committees. If you could pass on to the next slide, please. Appreciate it. So as I said, I oversee everything from a global perspective. And so it's required to be a visionary leader. And Carl, would you mind going back one slide? I actually wanted to point out the oath of a pharmacist. As an oath of a pharmacist, I took an excerpt from it that said, I promise to devote myself to lifelong service to others through the profession of pharmacy, and I will use my knowledge, skills, experience, and values to prepare the next generation of pharmacists. And that's why we are all here, to be able to use our knowledge, skills, and abilities to prepare the next generation, hopefully from this presentation. So if you go on, please. Okay, and of course you have to be a visionary. I want to pass one more slide, please. So before I go into an innovative pharmacy practice that we have here at Bay Health, I wanted to give some more information about how the viewers, people participating in this webinar are able to find more information on pharmacy. So there is a website called bls.gov, and that's the Board of Labor Statistics.gov. If you put in pharmacist or pharmacy technicians, you'll be able to find information about the career outlook, the career path, the salaries, college and education, whether or not the field is growing, which it absolutely is growing, if there's a need in our field, and the different areas of specialty. It also can break it down by areas of the country where individuals work. And again, that's BLS, Board of Labor Statistics.gov. So at Bay Health, there is an innovative pharmacy practice that has started that I brought whenever I came to Bay Health called Population Health Pharmacy, because I said the view is global. And so population health in general focuses on disease prevalence, life expectancy, and the quality of life within a population of people. So the population health pharmacists are clinical pharmacy specialists. As I said, they're clinical pharmacists with board certification and residency that oversee medication adherence, polypharmacy, or taking too many medications. If you ever have seen people say, oh, I got all these meds, I don't know, I'm worried about it, I'm concerned about it. The population health pharmacists are those ones that oversee that. Side effects and appropriateness of prescribing, and are actually a valued part of the medical team. Care is either embedded in a physician practice or it's over a telephone encounter with patients. They're credentialed also to be a member of the Bay Health medical staff. And we work through a collaborative agreement or independently to keep our patients healthy in and out of the hospital. Go on, next slide, please. So they get educational requirements that for the leadership path that I'm in is advanced management training. So if you choose to become as a leader in pharmacy, you have to go on to get a master's degree, either an MBA or a master's in healthcare administration. You also get a global, as I talked about, global healthcare. You have to become a fellow of the American College of Healthcare Executives. There's also a fellow of the American Society of Health System Pharmacies. And then also it's through different other organizations, such as the Pharmacy Organization, which is health system, diplomat in pharmacy leadership, or certified pharmacy executive leader. So as we all have been talking, lifetime learning, not only for my field, but for Carl's field and Candice's field and Katie's field, it's a requirement. It's key. Recognize that you always will have to have learning. There's continuing education requirements for you to continue to practice in your setting. Pharmacy technician, pharmacist, clinical pharmacist, pharmacy leader, but there also is lifetime learning if you want to advance in your career. As Candice talked about, advancing up the ladder as a pharmacy technician from a Tech 1 to a Tech 2 to a Tech 3. Next slide, please. So really talking a little bit about me, and also you. What piqued my interest? Hopefully there's other people out there like me. I love math and science. I loved how things worked in the body. And really, I found that many of people in my personal family had chronic healthcare issues. But they were afraid to ask. They were afraid to ask the question to physicians, really out of respect or reverence even for the title of a physician. But pharmacists, I noticed, were very visible, they were very approachable, and they're a respected member of the community. And that's exactly who I wanted to be. I wanted to be that individual. And before we go on to the next slide, one thing that I wanted to talk about, and I believe the next slide is question and answer, but one thing that I wanted to discuss is that in the state of Delaware, at University of Delaware, they created a program called a bachelor's in biological and pharmaceutical sciences that is in conjunction with Jefferson College of Pharmacy. And so in conjunction with Jefferson College of Pharmacy, after you've obtained your BS in biological sciences, you have to take a PCAT, or such as if you heard of the MCAT, it's medical college admission test, or the LSAT, law school admission test. There's a pharmacy college admission test. When you pass that test, Jefferson College of Pharmacy reserves 12 seats, I believe it still is, for Delaware residents to attend Jefferson College of Pharmacy, which is actually preferentially attend. After you graduate with your bachelor's in wherever you want to go, or it could be even some people only obtain just an associate's degree. Bachelor's is easier for you to get in, but associate's you're able to do that as well. After you obtain that, you have to apply to pharmacy school to go on for the additional 4 years to become a doctor of pharmacy. And so also within Mr. Gibbs talked about the Dimer program. In Delaware, we do not have a school of pharmacy. So as I talked about University of Delaware and Jefferson College of Pharmacy, it's because there is no school of pharmacy in the state of Delaware. So that's how the affiliation became created. So because of the DIMER program, the DIMER now recognizes as pharmacists as mid-level disciplines where there is loan forgiveness for pharmacists as well within the state of Delaware. And so that's something that you can refer to as well. It's underneath the SLRP, or the State Loan Repayment Program. So if you go on to the next slide. That really is all that I have, all that my team has, and we will entertain any question that you might have for us. If everyone could turn on their slides, that would be great. Their screens.
And we have questions. Oh, do
Yes.
we have questions? All righty. So I believe that, Carl, you may have handled a part of this. But how do you account for the differentials in, well, all the variables between patients, whether it's metabolic, gender, other drugs? I mean, how do you work through that whole process of figuring out what's the right dose, what's the right frequency, and so on?
Yeah, so sometimes it's clinical judgment and sometimes there's very clear data. So you can access programs and you can look to see if there's drug interactions, and it'll tell you sometimes what to reduce that dose by. If there's multiple drug interactions, you have to kind of take a mid-range approach. But then you have to roll into that also kidney function. So if you have kidney function, that usually overrides everything because that's where your clearance is. So a lot of it comes into clinical judgment and just rolling that patient into one. So a lot of times that's one of the fun things / not so fun things about pharmacy is it's always a gray area. And you kind of got to do research and then figure out what the best answer is. And if there's not an answer, you got to come up with conclusions to discuss with the physician and say, this is what I propose. What do you think? You kind of talk it out and come to an agreement with it. But yeah, so sometimes it's not clear cut like that. And you have to kind of go with clinical judgment and experience.
Right. And then this is somewhat related. So for complicated patients with an extensive, whether it's over-the-counter OTC or it's prescribed medications, we hear about medication reconciliation, and I think traditionally that happens sort of up front. But where do you all interface with that reconciliation?
So we do have a medication reconciliation team here. Actually, they're part of my team now. They actually see the patients on admission. So they're usually in the ER. We have part of the team in the ER, and we have a part of the team on the floor for direct admits. And their goal is to get patients within 2 hours of admission to the hospital. So they see them right on admission. They go up and they talk to the patient. They find out what meds they're on. Then they'll also consult a secondary source, which is usually either a family member, a physician's office, or even a pharmacy. They can call Walgreens. They can run reports and find out what they're on. They come up with that accurate list. They give it to the physician, let the physician know what's been missing off the list. And then they do the same thing at discharge. So at discharge, they look at the list before they get home and make sure that everything that they're on in the hospital that they're supposed to be on, they go back out on. So we actually have a 2-part process here, one on admission and one on discharge, and it's really the same thing.
There also is reconciliation of medications upon transition of care. So as I talked about the population health pharmacists, and they take care of patients after they've been transitioned from the hospital into the outpatient setting. And so in the hospital, we like to think of them as episodic care. It happens when they come in one of the most difficult times during their life, but a population health pharmacist will contact the patient, follow the patient throughout their time as discharged, or whenever they're living their regular life, and reconciling the medications that they're on, making sure that they adhere to the medications, making sure that there aren't any adverse drug reactions or so it's called complex care management as opposed to medication therapy management, because they're following through and doing that medication rec on an outside setting.
All right, thank you. Let's see. Cheri, the comment was made that do you have more than 24 hours in your day? And if not, how do you get it all done? We'll just put that out there. All right.
That's a wonderful team. That's how I get it all done.
This is a general question, but I can't wait to hear your answer. Does injection work better than pills?
Go ahead, Carl.
Not necessarily. So that's a common misconception. It really depends on the medication. So what we look at is what's called bioavailability. There's some medications that are 100% bioavailable, which means when you swallow them, 100% of the dose goes into your system, and they are not more effective than injections. And actually, some of the ones that are common with that are like pantoprazole that I talked about for heartburn, and a lot of antibiotics. But then there are some medications that, you know, they have to be given IV because they are just poorly absorbed through the stomach. But yeah, so that's a common misconception, is IV is not always better than by mouth.
And in fact, we convert medications that are bioequivalent is the terminology from IV formulation to oral formulation, so the patients can go home and receive the same effect of the medication that they did in the hospital.
Okay, hold on for a second here. I was just typing a response to somebody. Perhaps a somewhat unfair question, since none of you all have taken the LSAT or maybe even the MCAT, but can you speak to what the differences between them are?
I cannot. I've not taken those. I'm sorry.
No, we can't speak to that. All I can say is that they're all equally intense. And so you have to prepare in the same manner for your discipline that you want to go into.
Right, okay. And then every once in a while, I indulge my own questions. So we have prebiotics and we have precursor medications. Can you talk through with the precursor medications, what's going on there relative to what our body does to take them from precursor to active?
So I'm not sure if I understand your question. So like when you talk about like probiotics, what they are really just replacing the good bacteria in the gut to help with digestion. Because when patients take antibiotics or they have certain health conditions, those bacteria in the gut diminish, and then they have a lot of stomach issues. So probiotics specifically are actually designed just to basically replace that good bacteria. I'm be honest with you, I'm not sure what other precursors you're.
Well, I think another term for it is a prodrug.
So I'll try to address it. I think it's kind of trendy when people are hearing about prodrugs and precursor medications, because actually many medications are formed and found that way as a prodrug or a precursor medication. It's something that we learned about, that we knew about all along in pharmacy school. There are drugs called, well, such as, for example, there's a drug called pregabalin, and then there's a drug called gabapentin, which essentially is the same drug. However, it just depends upon where in the molecular structure, because that's where your chemistry comes from, that they find the mechanism of action of the drug whenever they're doing clinical trials. And so it's not as though they haven't always been around, because they have. It just has to do with the drug discovery process. There are alpha isomers and beta isomers, and this really has to do with the molecular structure of the medication, as I stated before. And just regular people beyond, outside of the pharmacy world, are just hearing about it. It's kind of trendy to hear about it. Nothing new though.
That sounds spot on. What's a good method of coordinating the use of a local pharmacy and using a mail order pharmacy?
I'll address that one. So it actually is patient choice. It's your choice of whether or not you could use a local pharmacy, or if you want to use a mail order pharmacy. Sometimes as well, it might be insurance that's driving whether or not you use a mail order pharmacy or your local pharmacy. Many times it has to do with your pharmacy benefit plan, that your employer or the organization of where you get your insurance comes from drives whether or not you go to a local or a mail order. Many times, many people choose to go to your local pharmacy because you like that one-on-one relationship. You like to hear from a human being. For people that love interacting with people, as opposed to not interacting with people, you go to that local pharmacy. Otherwise, mail order pretty much does the same thing. Local pharmacies and physicians can prescribe 90 days worth of medications as well. And so it really isn't necessarily as though they don't do the same thing. Coordination, though, as a patient, it would behoove a patient to try to get your medication at one place. Then that way, your medical team are able to identify side effects, drug interactions, everything that you're on. Because when you present to us in a hospital, we're trying to put together the pieces, such as what Carl talked about with medication reconciliation. So it's you got your medication, this medication here, this medication where are getting all of your medications? And then we have to talk about your not only your over the counter, but your mail order. And if you went to all these different pharmacies, although we have a database that might pull it, it makes it more difficult.
All righty.
Right, and to kind of
Um,
piggyback on what Cheri just said about that, a lot of times in retail pharmacy, what we see is that people that have the plans that make them have to go to the mail order pharmacies, they still are able to get their first fill at the retail pharmacy. So they're going to want to fill their antibiotics at the retail pharmacy, like the ones that they get from the hospital or anything that's short term. It can take 2 weeks to get a prescription filled mail order. That's the typical turnaround process. So if you start a new medication, you usually want to get that filled at the local pharmacy, and then you can also get that counseling, hopefully, from the pharmacist. And then at that point, if it's something you think you're going to continue and it's going to be a maintenance med, that's when they have to end up sending it to the mail order pharmacy if that's what their insurance wants. So that's what we typically see. However, from a retail pharmacy perspective, we also see people that have issues with mail order pharmacy. Sometimes the mail order pharmacy will fill a 45-day supply instead of a 90-day supply because they didn't pick up something that the doctor wrote wrong on the prescription, or they just have questions about it in general. So then they call the local pharmacy so that we can then counsel them on the medication, because we are a lot more accessible as a retail pharmacist than they are as a mail order pharmacy. Sometimes the mail doesn't deliver it, and then they run out of prescriptions. So then they're like, oh my gosh, I don't have any medicine. What do I do? So then the doctor calls in like a couple days supply, a week, 2 weeks, a month, whatever the insurance will cover. And then the pharmacist at the retail pharmacy will have to call the insurance company so that we can get a short fill override for the patient until their mail order drug supply comes. So that is also an extra burden on the retail pharmacies when the insurance company requires people to go to mail order. So there is a bit of trying to pick the pieces up when we do that, because we don't like when people do polypharmacy. We like when they stick to one pharmacy, but at the same time, sometimes you just can't avoid it.
Right. It's interesting. You mentioned the term polypharmacy, and that that has a couple of meanings. So polypharmacy in complex patients that are taking a lot of medications. Again, I guess part of medical reconciliation and pharmacist expertise, how do you help coalesce and work with the medical team to trim that down to a manageable list of drugs that they really need rather than just what they've always been prescribed?
So I'll start and then my team can pick up. Whenever, particularly in a hospital setting, when you come into us, that is the best time for that to occur. That is what we do. So we absolutely start with the med rec team that comes into the hospital, and then the prescribing occurs based upon what the patient was on. And then the physician and the pharmacist and the medical team start whittling down what the patients might be on, where your drug interactions and where your side effects are, just to level set. It's a chance for us to level set the medications that you're on, particularly in a hospital. At Bay Health, because of our population health pharmacy team, that's also something that we do, is we address when patients are for that longer period of time, because a patient's length of stay in a hospital is generally 3 to 5 days, depending average, right? But in population health pharmacy, they have the lifetime, the lifespan of patients. And that's constantly what they're working on, is looking to try to gather and wrap their arms around all the polypharmacy that might occur out there and whittle down and find additional information about, really the goal, as I stated in my presentation, is to keep the patients healthy, keep you out of the hospital, really, for you to live your life in the community as opposed to ending up back with us again. Anybody else want to pick up?
Yeah, I'll say also, like part of the MedRec team, and I don't do the medication reconciliation, but I do the counseling. With the medication reconciliation team, one of the things they can do is look for combinations they can put the patient on. So sometimes they can be on a dual blood pressure medication or a diuretic or anti-diabetic medications where they're on several presentations, but they can really get one pill that has both medications in at the same time. So that narrows it down a little bit. I know me personally, when I talk to my cancer patients, I use that example of pantoprazole in my slides because that's actually one of the things that I find the most that patients are on that they don't need. When I see that, my first question is, how long have you been on it? And why are you on it? And usually the response is, I've been on it for a few months and I was on it because they started in the hospital and just never came off. And then at that point, I have it stopped because there's really no reason to have it. So it's really looking for, do they really have an indication for it? And if they do, can we scale things down by combining medications or even maybe using something that's longer acting? So instead of taking something 2 or 3 times a day, they can take something once a day. So whatever makes it easier for the patient.
Righty. As a pharmacist, and let's talk first specifically about in the hospital setting, do you also compound medications?
The technicians do. Candice, take yourself off mute. Yeah. there you go.
Typically, the technicians are the first point of contact for compounding medications. However, there are instances where things may get a little bit busy and overwhelming for the technicians, and we do have pharmacists that will jump in and assist the technicians when they need to.
All righty.
So it's an adamant yes, and we all do, but primarily the technicians.
Okay, and peeling it back to another level, what is compounding?
Candice?
So it's a process where we are actually mixing and making the medications. We'll have a intravenous vial of medication that could be a powder substance or a liquid substance, where we actually have to sometimes reconstitute the medications in order to get the medication to a state where we can mix it into a solution in an IV bag that would be administered to a patient by the nurse.
Great. All righty. Oh gosh, there's so many questions. Going back to the beginning. Could xylazine be considered more deadly than fentanyl or other deadly drugs? I think you guys said, but I forgot what you said.
So the problem is xylazine in and of itself is not necessarily the issue. The issue is when you mix the xylazine with the other medication. So if you mix it with the fentanyl, you mix it with the heroin, you mix it with whatever they want to mix it with, that's where we then see the majority of our problems. Because right this second, our problem is not with xylazine in humans by itself. It is that they're using it along with those other opioids.
Right, compounding with not knowing what you're doing.
Precisely.
Here, this is a good anti-something stewardship. Can too many antibiotics be prescribed, and if so, contraindications, what do you do about it?
So there can be too many antibiotics prescribed. That's kind of a loaded question. So what we do here is we have one pharmacist that looks at the prescribing in general, and throughout the United States, it's typical that antibiotics are overprescribed. So you go to a physician, you got a cold, you got a headache, whatever, and they give you an antibiotic and say, here, take this. But the majority of the time it's viral, and the antibiotic will not work for a virus. So you don't really need it anyway, but they just give it to you as like hey, this may make you feel better. So what we do in the hospital is we have certain situations where they'll draw either a blood level, they'll take some sputum, they'll take a urine culture, whatever it is, and they'll run it through the system and see what antibiotic matches up the best. So there's things that are called broad spectrum antibiotics that kill a lot of bacteria, and there's some that are more narrow that kill certain bacteria. And your goal is to narrow that antibiotic down to exactly what you need, not something that's going to kill everything. So you don't generally need too many antibiotics because unless you have multiple infections going on. So if you have different types of like anaerobic bacteria, gram-positive, gram-negative, you may need different antibiotics, but if you don't have those, you don't necessarily need them. As far as it being harmful, it depends on the antibiotic. So, some antibiotics can have some severe side effects, like, a very common one is called Bactrim. It can drop your sodium down to deadly levels. You have other ones that can cause a lot of diarrhea. And then to the point that when we're talking earlier about probiotics, it can actually kill the bacteria in your system so much that you get another infection called C. diff, which causes a lot of diarrhea and it's very hard to get rid of. So they can be harmful if you take too many, but our role here is to make sure that we follow the physician and say, hey, we looked at the labs, you don't need this many antibiotics, this is the one you should really be prescribing. Or, it's a simple urinary tract infection that will go away in a few days, so we don't really need to treat it right now anyway, because, so it just depends on the situation, but you can't ever prescribe. And that's the whole point of the stewardship team, is to stop that over prescribing.
There also is a risk of multi-drug resistant organisms. We call them MDROs. And with the multi-drug resistant organisms, patients might take antibiotics inappropriately. You might take, oh, this person that I knew was sick, I'm going to just take their medication. But that actually will limit the medical team's opportunity to be able to treat you because you have drug resistance. And so we actually monitor to find out which medications now have resistance because of overuse of antibiotics, such as what Carl was talking about. And we're getting to a point where there aren't any more out there whenever someone has overused it too often. And so then you have to go to what we call older medications that might have more increased side effects, just really trying to do the best to prevent the patient from having sepsis or even the worst case, which might be death.
Right. And it's not in the news as much right now as it was, but super gonorrhea is a sexually transmitted infection that we've heard a lot about in terms of its incredible resistance to prescription treatment. Let's change the tone a little bit. What's the most challenging aspect of working in the pharmaceutical field, and what are the most rewarding things?
So,
okay.
Go ahead, Candice. No, you can go first. Go ahead.
Thank you. I'll speak to that first. As a pharmacy technician, sometimes the workload can be pretty heavy, especially depending on the time of year. Flu season, of course, people are sicker. So then there are more medications that need to be dispensed. During COVID was a really intense time trying to keep up with the workload as well. However, working in pharmacy has still been a very rewarding, especially for myself personally. I also worked as a technician prior to becoming a supervisor, and I mixed chemotherapy for patients. So as an oncology pharmacy technician, I've also been able to have the reward of hearing somebody ring the bell that they completed their chemotherapy and knowing that I directly was involved in their treatment and helping a patient get better. Also seeing patients with IVs that I've prepared myself connected to a patient that's, in the hospital and then seeing them be discharged, things like that I've also found very rewarding. And then now in my position as a supervisor, I have experienced a lot of the things that the technicians that report to me are having, and I am able to now help them and be in a position where I can help people that were once in my position to learn and to grow and to be successful.
All right. Double question here. Number one, what is a bioidentical drug, and are they the future of pharmaceutical treatment?
I've never heard the term bioidentical drug.
Bioequivalent, perhaps?
Or biosimilars?
Biosimilar.
Yeah, so biosimilars, they're actually, we use those here. So when you talk about a generic medication, so just say a blood pressure medication, I'm going to use lisinopril for an example. You can easily recreate that in a lab. So you can go from a brand to a generic very simply because it's a very simple molecule. But when you talk about things called like monoclonal antibodies, they're proteins that are very complex, and even lot number to lot number within the same manufacturer, there's variation in the medication. So what biosimilars are they're considered highly similar to the proprietary medication. So you'll never get exact, but they've shown in studies that they're highly similar to the mechanism and the side effects. So because the outcomes are the same and the side effects are the same, we do utilize those here because they're generally a lot cheaper. So you may pay, $5,000 for a brand name, but for a biosimilar, maybe $2,000, you get the same result. So they are the wave of the future. Unfortunately, with the FDA, you can't just swap one for one. You actually have to have an order to do that. So we have a mechanism here at Bay Health where, I just kind of get a statement from the oncologist saying, yeah, that's okay. And we just change it for everybody. And that's our formulary alternative. So yeah, biosimilars they're the new thing.
And I like to tell patients, family members, everyone that if you're concerned about going from, let's say, a generic to a brand to a generic, or from the proprietary drug to a biosimilar drug, you're coming into a hospital with them. So in a hospital, that is what we use. That is how you get better in a hospital, on your biosimilars and on your generics. And so really, you can trust that it'll treat you.
Right. So on the same theme, and remembering that I'm actually asking the questions generally as people are typing them, I believe there are bioidentical hormones.
Yes.
So talk to us a little bit about what those are, just since we were talking about similar and identical.
Yes. So bioidentical hormones are really things that they use, particularly in treating women with menopausal symptoms. And so there are different agents that they try to have the same outcome as Carl talked about with biosimilars. It has the same outcome in improving menopausal symptoms, but it's used, it's a different entirely compound. So that's essentially what it is. It's a different compound that has the same outcome to treat, or a similar outcome. I can't say it's exactly the same, but to treat a disease state.
All righty. So we hear a lot about GLPs, the glucagon-like peptide 1. And there's a question here about shortages of diabetic medications that are used off-label for weight loss and additional brand name. So just to talk to us about GLPs in general, and then specifically about shortages.
You want to go, Carl? Or do you want?
Sure. So GLPs, I mean, that's a hot topic nowadays, the GLPs, because obviously somebody with diabetes really can benefit from them, but then they create shortages for the weight loss. There's a lot of off brands out there and compounding pharmacies that will make GLPs for patients at smaller doses. They do have their place, they do have their benefit, they seem to work. But there also seems to be some longer term data that are pretty new, and as things get used, you start seeing more and more issues with them. So the data on that's still not quite mature, although you're starting to see it being used more and more. But with drug shortages specifically, that's always a hard topic, especially in cancer medications, because somebody's life is depending on that medication, and you might not be able to get it. So then you're looking for the next best thing, or the drug that may be close but not quite the same thing. So, here we deal with shortages a lot. We have a mechanism where we try and get this doses out of the same vial for patients that we can spread the dose out. Sometimes we'll have to extend their cycle from 3 weeks to 4 weeks. We try and ramp up stock. So we have a lot of mechanisms here to try and get past those shortages. But when they do hit, that's when we have to start telling patients that we may have to delay the therapy a little bit, or reduce the dose some so they get some benefit, but not, might not get the full benefit. But, when a national shortage hits, that's always a major problem. And it's not just cancer medications. You get it once in a while for antibiotics. You'll get it for diuretics and things like that. But with non-cancer drugs, a lot of times there is an alternative that you can turn to that's just as effective. I think the shortages take its biggest toll on cancer medications.
So specifically for the GLP-1s, I'd just like to add in that is a supply and demand issue totally from the very beginning. It started out that GLP-1s really weren't the hot topic for weight loss until people found out that the patients who were diabetic that had cardiovascular disease were losing weight and actually able to lose weight at a faster rate than other individuals. And then so it was used off label just only for weight loss, which caused the supply to really drastically decrease for the individuals who really qualified and needed them. And so the demand was much higher than the supply. So now actually we're in the point where actually the supply and demand are exactly where it needs to be, where there is actually more supply. Because the pharmaceutical manufacturers started increasing and making more and more and more. So that shortage is no longer there.
All righty. Well, that's good to know. Let's see. Is there a big difference between sublingual, injectable, or pellet tablet medications?
No, again, that goes back to the bioavailability. So sublingual is generally quicker than swallowing a tablet because there's a lot of vasculature under the tongue. And you don't have to wait for it to be broken down within the stomach. But then your IV works almost immediately because it's going right into the bloodstream. So your pellets, they tend to be slow release. So you see pellets when they're injected, they'll release over time. So it's really what you're looking for as far as timing of the medication being released, and then how quickly you want it to work. So that's really what it comes down to when you're looking at sublingual versus IV tablets and pellets. And one more thing with the sublingual is sometimes you have patients that like antiemetics, if they're vomiting, they can't swallow a tablet and they don't have an IV in because they're dehydrated. So you'll give them something under their tongue so they can get that antiemetic in and calm their stomach down a little bit. So it just really depends on the situation and what you're looking for as far as how quickly the medication is going to work.
All righty. Oh, while we're on that topic, we hear about extended release medications. What does that mean?
So extended release medications are one that are designed to release over a longer period of time. So as opposed to getting one just like spiking your blood levels, it'll go up and stay over time. So it's being released more slowly. And what that does, that the benefit of that is you have a more prolonged action. And you can also, instead of taking something 2 or 3 times a day, you can take it once a day because it's being released slowly as opposed to immediately when it hits your stomach and is absorbed.
And how do they actually do the extended release? What's going on there? A shell that dissolves more slowly in the digestive tract? How does that work?
Yeah, it's there's different ways they can do it, but you're right. One of the ways is like a shell or a wax matrix that can go in, and it just degrades more slow in the system. Some will have a buffer on it so that it doesn't really get absorbed into the stomach as quickly. It goes through the GI tract and it's absorbed through the GI tract. So it really depends. There's a lot of different mechanisms for extended release. There's not just one way to do it.
All righty. Kate, you look like you were going to add something there.
I was. So in the sense of the extended releasing, do you remember the chart that I showed in the very beginning of my presentation where the drug has a certain time to act and then it's going to release over time? So you can use that graph to kind of look at your immediate release versus your extended release. So immediate release might have a higher peak, like a higher line, and then a shorter time to eliminate. But an extended release is kind of like if you put your hand on it and flatten it out, then you're going to get, might not be as high or it might be as high, but it's going to have a higher peak. So it's going to start flattening that top out, and then it might have a lower, like a longer line towards the end. So it's just going to flatten that graph out instead of it being really high. And then what you tend to notice is that while the one's going out, you take the next dose, it's kind of going to meet it in the middle, or you're going to meet it above that to try and keep that line flat. So it's essentially, instead of having a bunch of peaks and troughs, you're going to have that flattened line to help keep a steady state of drug level in the body over that certain time period.
All right, and along a similar or maybe not similar theme, some medications come with the instruction, take at night before bed. Why?
There's various reasons for that.
It's a molecular. Sure.
Yeah, it's molecular.
It's
It's how our
compound.
body works. It's the chemistry of our body. It's how certain hormones are made overnight versus during the day, like cholesterol medicines, for example. Our body makes cholesterol when we sleep. So if we take the cholesterol medicine at night before bed, it's going to work better than in the morning. However, if somebody is going to forget to take their medicine at night and they're used to taking it in the morning, guess what? Take it in the morning. I'd rather you remember to take it than not take it at all. But at the end of the day, it's going to work better if you take it at night.
Yeah, that's your chemistry. The background that you have to have math and chemistry, knowing peak and valleys and compounding, keep peak and valley and just your chemical makeup of medications as it relates to your body and the labs that Carl talked about, how your liver breaks things down, how your kidneys break things down. So your onset, elimination, things like that. It's called your pharmacokinetics is the real terminology.
All righty, very good. So Chloe asks, as somebody who is a junior in high school and wants to become a pharmacist, what do you think is the best path to take in college? And then part two, I want to open my own pharmacy, but I don't want to do retail pharmacy personally. Do you think that industrial pharmacy is a good career path? Take it away.
So,
I'll speak to a small portion of it.
okay.
As somebody that's a junior in high school, Bay Health, our organization actually offers a volunteer program for high school students. So you would actually, as a technician, be able to come in and work a few hours here and there as a technician so that you can build up that experience. You are able to become a technician once you turn 18, and then that can initiate your experience in a pharmacy setting prior to going into college. But Cheri, Carl, and Katie would be able to have more insight on pharmacy school.
Good, Carl.
So to start your career path, I agree with Candice that the best way to do it is to get as much exposure in pharmacy as possible before you get to pharmacy school. So there's really two types of pharmacy schools if you think about it. So the first one is a 6-year program where you go right in from high school, you do 2 years of undergrad, and then you do your 4 years of pharmacy school, and you come out with your doctorate in pharmacy. The other way is an 8-year program, and that is programs that you have to go do an undergrad for. And there's usually pre-pharmacy classes or pre-medicine classes. And then that's a 4-year degree, and then you get into your 4 years. So they both have the same education. It's really just the pace that they move at. They both come out with a doctorate.
There's only 5 6-year programs left in the nation, by the way.
Yeah, so get in now while you can.
Yeah.
And then while you're in pharmacy school, you have to do internships at the end of your pharmacy school. So that's when you start working in different settings, whether it's retail, it's hospital, it's industry, it's whatever you want to work in. That's where you start doing your rotations, you do your internship, and then you graduate, you take your test, and you can do your residencies and then become a pharmacist. But to get started, my advice would be to get as much exposure now as possible. I think it would make life so much easier in pharmacy school. And in my personal opinion, this is just me, my exposure was in retail and then went to pharmacy school. I think my pharmacy schooling would have been a little easier if I would have done hospital first, because you get to see more medications and more things in hospital than you do in retail going into pharmacy school.
Katie, did you have anything you wanted to add?
So I also worked as a tech when I was still in high school, but I did it as retail. After I got in college, I continued working as a tech throughout my time in school, again in retail. But there was 1 year that I worked as a hospital technician because I wanted to understand how to mix IVs and what all that meant, because I knew it was going to be really different. So when I did that, I absolutely loved it. But then there was a JCO requirement that you had to work so many days, and I didn't work when I was away. So I didn't end up keeping it up. And then I ended up going into retail because that's the field that we all kind of think of when we think of pharmacy, even though that's just kind of the cookie cutter, like where people think they end up having to go, not realizing that there's the rest of the pharmacy world out there. So when I was doing my rotations, I thought that all the stuff was really cool, but I didn't think that there was any programs around here that did all of that fun stuff. And now that I've come to Bay Health, we do it all here. And I went from being stuck in a box in retail, and there were times, I'm not going to lie, I did not like my job at all. I hated it. I wish I didn't go to pharmacy school. Since I joined this Bay Health team, my entire outlook on life has changed. I love my job. I can say pharmacy is an amazing career path. I make a difference in my patients' lives every day. and I love coming to work. I look forward to coming to work every day.
So might
Oh,
I point out, just to answer the question directly, I'm not sure what industrial pharmacy is. So whenever she said, what's your path to that, owning an industrial pharmacy, there is industry pharmacy, and that is not owning. Industry pharmacy is the same as a pharmaceutical company. And unless if you own the conglomerate, such as Pfizer or the names of the pharmaceutical company, you would be a pharmacist who works in in industry, also known as a pharmaceutical company.
Right, right. I think that may have been swapping commercial for industrial.
Okay, gotcha.
Yeah, yeah. All right, well, we're to that point where we're limited on time and we have a lot of questions. So do you all have the Q&As open that you can see them? Because it might be easier if you rapid fire and go through them. We have some people who have asked a lot of questions. And I'm going to go ahead and dismiss those so that we can get people who haven't been able to ask questions, but I'll kick this off. How often do pharmacists get a medication rejected by the insurance company?
All the time, every day. It was the story of my life when I worked retail pharmacy.
All righty. All right. You guys take it away however you want.
Okay, so I'll try and man this and we'll go through it quickly. Talked about pregabalin and gabapentin, pretty much the same drug. Yes. Does hospital pharmacy fill prescriptions to give patients going home? Yes, we do. We have outpatient or community pharmacies connected to our pharmacy. And so, yes, we can fill them, but only in the state of Delaware, it's only inpatient or outpatient pharmacies. Have you had patients go to, let me see, what barriers to treating someone who is abusing, what are the barriers to abusing xylazine? Do we have time to even talk about that one? It makes it very, very difficult to have a patient really to get them coming down from the high and also to treat their wounds. I don't know if there's another thing you wanted to add about that.
Yeah, so the only other thing I can say to that is that right this second, we don't have FDA treatment guidelines. So we're still trying to figure it all out. So in that sense, we can't, the barrier that we're having to get the studies to do the treatment is that you have to have patient consent to join a study. And because they're on that high and they're coming down, we can't get their consent to even get them into a study to then get them treatment to get the guidelines. So there's just barriers all the way around to even try to develop those guidelines.
Well, this one, do children use the same medication that adults take if the dosage is different?
They do. And actually, depending on the medication, sometimes the dose is actually a little higher in children the way they metabolize it.
Okay. Have you had many people go to the hospital because they've gotten sick taking peptides that are not for people that are still being researched? I can't say many.
I've not seen any.
All righty. And we're right on time. Thank you all. That was fascinating. I appreciate all of our presenters this evening, and we will see you all next week. Have a good week. Take care.
Thank you.
Good night.
Thank you.
Thank you.
Thank you.
Have a good one.
Okay, bye-bye.